since we are short on time, we'll just move straight to the point and get to how can infertility be addressed within the context of primary healthcare as a first line of prevention and care? For the questions of Dr. Talwar.
Thank you so much, and thank you so much for ET Health to invite me here. And thank you so much, Prabhat, for setting the context. So my background is that, how I look at this question is that I have worked in Indian Army for nearly 30 years, and there's a government organization. And following that, now I'm in corporate and wearing multiple hats. As Dr. Malpani brought it out, being in the board as well as being a clinician. It's a very nice question. I look at it in a very different perspective that in our country, we have around 28 million subfertile couples. 28 million is a huge number. And in case we just break it down, barely 1 million, 1% of them are able to come to us for some treatment. And this is from ETHealthworld records. So only 1% of the people in our country who need treatment are able to reach us. So where do other people go? How to reach them? And we always boast about large number of IVF cycles being done in our country. Now, in case I look it back, I think sir will agree with me that when we started our journey around in 1978, India had the first baby born 3 to 4 months after the birth of Louis Brown. The IVF result that time was barely 5%. And now it took us around 44 years to reach the magic number of 2.5 lakh cycles. IVF cycles in year 2021. And by year 2025, we'll be touching the number of around 5 lakh cycles. And then by 27, we'll be touching a number of around 7.5 lakh IVF cycles. So it's growing very rapidly. So looking at it in a different perspective, that how do we reach that other people don't reach us, I think we have to change our perspective and reach our the tier B, tier C cities. The most important part of it will be that we have to create, first of all, education. We always talk about corporate social responsibility, but I think the time has come to have our own doctor social responsibility where we reach the people in the tier B, tier C cities and have some sort of collaborations with the primary healthcare centers, maybe with Anganwadi workers or Asha Didis, and spread a word, spread education about the infertile population. Infertility can be a big stigma, and infertility is what we call, when we talk about in vitro maturation, we talk about neo techniques. But in a small village, it can be curse, it can be the people go for witchcraft, they go for religious healing. They feel that mera karma hai, aisa mere saath mein ho raha hai. So we have to break these taboos. So what I feel is that we should be bringing more semblance into our working way. We have to create awareness, reach the peripheries of the country, and educate the people who are the majority and they are staying in the villages.
Thank you so much, sir. And since you mentioned about stigma, I have a question for Dr. Tang. Could you share some broader perspectives on public health and infertility on this?
Thank you, Prabhat. Thank you, ETHealthworld, for having me here. It's quite a privilege and pleasure to sit alongside Dr. Talwar. Thank you, sir. I think we sometimes make the mistake of viewing infertility through a service delivery perspective. I think Dr. Talwar alluded to perspective. So I'm going to give you another perspective because I have worked in public health for a fairly long time, not in infertility. My bulk of my work has been in sexual and reproductive health, but I think it would be useful to extrapolate some lessons learned over there. Look at the economic perspective of infertility treatment. IVF is one part of infertility treatment, and all our attention seems to be focused on IVF alone when it comes to infertility treatment. Not realizing that it's actually only maybe 10 to 15% of all patients who come to us for infertility who actually need IVF. You are therefore looking at something like 80 to 85% of patients who can do well without IVF. And with the government's new concept of wellness centers, replacing primary health centers, I think it's a great opportunity to capitalize on this and at least make these wellness centers have enough capacity to reach at least up to pre-IVF. So that's the economic perspective, which I think we tend to neglect because IVF is obviously the more, how do I say, glamorous part of the whole gamut or treatment. Look at it from a more broader public service perspective. And when I say service, I never mean altruistic service, because I think altruistic services don't last, are not sustainable. That you have to be rewarded for the services, then only those services will last for a longer time. And it would be a mistake to look at infertility treatment from the service delivery point of view alone, as far as public health is concerned. It's an entire cycle. You have to do IEC, information, education, communication. You have to destigmatize the problem of infertility in our community. And by doing these two things, you have to get the patient to the clinic, where she should be treated respectfully, efficiently, and safely, and then take feedback from the patient. And I think in all this, what we are doing is only service delivery. So I think you need to look at public health or infertility in terms of public health from this much broader perspective, and also, of course, understand the fact that the ART Act is now here, and if it's a government institution, it becomes that much easier for that institution to follow the Act, because they're already government. And this is again something which we have seen when it comes to ultrasound for PCP and DT, when it comes to abortion and contraception services in SRH. So I think we should stop looking at infertility, particularly in the public health sector, very narrowly or in a silo of service delivery. We have to look at it from a much broader perspective. And I think conclaves like this could certainly help to do that.
So taking it ahead, this question, if anybody would like to take it up, is accessibility to quality IVF treatment a problem, or is there a deeper problem associated with society, education, awareness, and more?
Yeah, thank you so much, Prabhat. As I brought out initially that we have a wide disconnect between the urban and the rural populations. And that is not only in terms of per capita income, that's also in the terms of our education, our upbringing. And if you look at it, the place where I work, my average age of patient is around 40. In case I get a girl who's less than 38, 39, I feel, what's wrong? How could she reach me? Average age for me is 40, 41. In case you go to small villages, which is the heart of the country, their average population may be 23, 24. If they can't have a child by 25, 26, then something is wrong with them. So I think there's a big social divide in terms of their education, the demographic profile, and there are different sort of illnesses related with where we are staying. In a village, when you go to a small tier B, tier C city, the problems can be different. They may be having more of things like tubal blockage. They may be having low sperm count due to pesticides. But if you come to a big city, the problem can be due to stress. It may be due to their bad lifestyle disorders. They can be leading to the problem. So I think time has come that when we try to connect the dots, bridge the gaps, and reach the people by educating them. And education has to start from the peripheries. And for the education, as I said before, that for us, it can be a disease as per WHO. Infertility है तो क्या है? IVF है. और सर आपने जो बात बोला, बहुत ही अच्छा बात बोला कि IVF is one of the last things which we offer to the patient. In the holistic care, we look at the patient in terms of giving them basic treatment. Even a touch can make them conceive because you're decongesting their hypothalamic pituitary axis. IVF is not needed for them. So I think that we have to educate people, and it is stigmatized. In a village, the lady may be called a banj. She may be they are undergoing divorces. They are being separated. So I think we have to establish, Prabhat, some sort of small awareness camps, school camps. We have to destigmatize the infertility problem by having broader outreach to small parts of the country.
As you have rightly said, like catch them young and treat them and educate
very
them.
Very important. 18% of the 18% of the causes of infertility can be due to the tubal blockage. And that comes from disease like chlamydia, or it comes with the tuberculosis. So in case we catch them young, I think we can definitely, so it's preventive and curative as well as.
Dr. Tank, moving ahead, what do you think could be the role of education in such a scenario?
Thank you, Prabhat. I think Dr. Talwar has already emphasized about the need for education. But again, when you talk about education, there are sort of upstream issues and downstream issues. And you can't really look at education purely in terms of giving knowledge. I think education has to be more than that. Education also has to focus on empowerment. It also has to focus on healthcare providers. And I think we do make a little unfortunate error when we, in conferences, call only physicians. I think education is equally required for the entire healthcare ecosystem, starting from the receptionist to the person who gives the jar to the male for collecting the semen sample, to everybody who has any touch point with the patient at all. So I think you have these two broad silos, and they shouldn't really be silos, but you have these two broad silos of education. There's community education, and then there is education for the entire health ecosystem at every touch point where the patient goes. But I think, and I'm going to take a minute here, Prabhat, if you'll allow me.
Absolutely, sir.
I think the policymakers, activists, anybody who has any word in either governing or forming the ART Act also need to be educated. If you ask me, I think the way the ART Act is drafted represents a failure of the entire healthcare ecosystem in giving a positive narrative. I don't know whether you all have read this book. It's called The Politics of the Womb. It's by a very famous activist who's done absolutely fantastic work in child sexual abuse and so on. And I honestly expected a little better book. But if you read that book, you will actually be shocked as to how anybody undergoes IVF. You know, the way, the language that is used, the emotive kind of arguments that she has made, that in IVF, the woman is subjected to a tsunami of hormones which do this, that, and the other. And unfortunately, as healthcare providers, we have not been able to put a positive narrative forward. And I'm going to deliberately use the word narrative and not spin, because it's not a spin. It is in fact a narrative. We have not been able to tell people how good IVF is, how many families are today complete because of IVF, how satisfying IVF treatment is for those who deliver. And I think this also needs to be brought forth, and this also is a part of education. So while we want to educate the community and we want to educate physicians, we also need to educate everyone about this positive narrative of infertility treatment, which we don't seem to be doing very well.
So in this context, there is absolutely an urban divide.
Yeah.
If we agree with that, urban and rural divide. So how can we breach that?
I'm not sure that there's so much of a divide now, Prabhat. I'll tell you why. I think I manage around 17 IVF centers all over the country. And we have centers in very small places. I have a center in Yavatmal. I have a center in Chandrapur. I have one center in Jabalpur since a long time, when Jabalpur used to be a small place. And when I speak to patients over there, I don't find them to be less aware of the problem. I don't find them to be less inquisitive about what we are going to do in terms of the treatment. I also don't find them less affording, honestly speaking. And I think this urban-rural divide now with social media has actually been breached to a very large extent. And I think the pandemic did have a major role to play in that, because we were forced to switch to electronic media. And if you go to any restaurant in Bombay, if you go to a train in Bombay or a bus in Bombay, most of the times you see people doing that rather than doing this. And whether you go to a restaurant in Bombay or you go to a restaurant in the smallest possible place, most people are still on their phones. And the fact is, therefore, that I don't think there is as much of an urban-rural divide as we think there is. And therefore, to breach that, we need a homogeneous approach and not a heterogeneous one. I don't think we should be catering to the rural audience separately and the urban audience separately. They are both equally intelligent. They are both equally. In fact, I have this thing which I say when I talk about abortion, that poor does not mean stupid.
Absolutely.
You know, actually, if there are many studies, particularly in sexual and reproductive health, which show that if patients are counseled properly, the poor actually tend to follow directions much better, because the rich sometimes seem to think that, all right, ye to mujhe malum hai.
So in that context, I have a question for Dr.
I'd like
Talwar.
to add one thing here, that COVID has done a very good thing. I think nowadays, ladies who come to us probably in an Audi or they come to in a cycle rickshaw, पहला सवाल होगा आपके पास लेज़र है? I was quite shocked. How does she know about the laser? But they all have learnt about laser. And then Dr. Google just captures them like this is spider web the Google creates, YouTube creates. Once you enter, somebody will catch. You will catch or I will catch. So we start sending them so much literature to read that they are very educated. So here issue is about the accessibility. They have the awareness, they have the knowledge, they have the money too, as you rightly brought out. But I think accessibility has to be increased, and this is what I like to add on, sir.
Just as a joke, so one patient asked me once, do you have laser? I said, yeah, I have a laser pointer.
So this question is for Dr. Talwar. How can adoption address the issue of infertility?
Okay, so it was, I think, how I recollect, go back to adoption, that around 6 years back, I was one of the adoption officers for Indian Army. We have around 7 centers in Indian Army, and we got a long waiting period of the people who come for IVF. So I was told by our senior people, our chiefs, that why don't we start an adoption center? So I went to the CGO complex, and they call it Kara. That is, Kara is the place from where we can get the babies. I went across nearly 8 to 10 adoption centers all across the country and in Delhi. The average waiting period for an adoption is around 3 to 4 years. It's not easy. Adoption is a very good option, but it's as difficult and messy. We can't get a child. And secondly, people don't want to have, people all want to, they want to adopt. But when they adopt, they may be wearing a pregnancy belt. They want to tell people that they have delivered the child themselves. So they all want to have a young children being adopted, which is difficult to get. So this is my experience that adoption is a very wonderful way. And I was watching the movie 2 days back, movie called Circus, in case you have seen it. That's about 2 brothers being adopted. It's on Netflix, you can watch it. Lovely movie about genetics and whatever we spoke about a few days back. So I think adoption is a very good option, but adoption is not an easy way. So in case we can make it, you can, as from ETHealth, you can spread awareness, and sir can spread awareness from FOGSI. I think it's a good option, but we all like to adopt young children.
Absolutely.
Can I just add, Prabhat, if you
Yes,
don't
sir.
mind, that I think it's a false equivalence. I don't think adoption can be equated to infertility treatment. Adoption is one of the choices.
Yes, sir.
Right? And this is one of the choices that you offer the patient. But at the end of the day, the patient's wishes have to be respected. And frankly speaking, even now, even at the very first consultation when I consult for an IVF cycle, I do give the option of adoption. And I have yet to see a patient who jumps at the fact that, yes, there is something which is an option for adoption. The thought is always that, let me try first. And then if it doesn't work, I will think about adoption. I mean, the desire to procreate, honestly, is so strong one way or another that it's actually quite a task to convince an infertile patient for adoption. And therefore, I think you can't equate infertility treatment and adoption. It has to be one of the choices. It is a good choice, no question about that, but I don't think they are the same.
Thank you, sir.
Actually, with so many facilities available nowadays, anyone can become a parent.
Exactly.
So then, and for adoption, they have to spend so much of money and so many chakkars to their adoption centers over 3 to 4 years, and so much is the paperwork that they have to fill in thick files. They say, okay, 3 IVF kar do, I'll have a more cumulative chance of getting a live birth rate. So that's my feeling.
Okay. Thank you so much for your insights on this. So now we are running short on time, so we'll just push it fast. How can fertility treatments be made available to all sections of society? How can public-private partnerships address this issue? And how can outreach and awareness be increased? Dr. Tang, please.
So that's actually 3 questions, Prabhat. But let me try and sort of, bundle it all together. They say that the government healthcare should play the role of either a provider or a payer. To become the provider, you need infrastructure and you need human resource. And unfortunately, we are short of both of them. And both infrastructure and human resource take a long time to build up. And that's why Ayushman Bharat. I'm a fan of Ayushman Bharat. I mean, I know it has its deficiencies, but I think it has tremendous potential over a period of time, particularly given the way the government is tweaking. What remains unsatisfactory, if I may say so, about it is the price points. And if we could talk to Niti Aayog, which we do on and off, and try and arrive at a price point which is suitable for both the private as well as public sector, I think it would be very easy for the government to become, be a payer rather than a provider, and use its capacity as a payer to fill the gaps in public health infrastructure by using privatehood. The problem, as I said, is always the pricing. And the second problem in public-private partnerships, honestly, is the fact that a public-private partnership is always skewed in favor of the government. And partnerships, as you know, will never work if things are skewed in favor of one partner. It has to be a win-win situation. I'll just give you an example very quickly because time's up. I was in a discussion at Niti Aayog once, and we were talking about public-private partnerships, and I said, please don't look at money as the only incentive for private sector. There are several non-monetary incentives that can be given. I run a hospital in Mumbai. I have 27 licenses to procure to run my nursing home, and some of them are actually annual, and all of them are with different agencies. I said, give me a single window system. And if you give me a single window system, I will be more inclined to participate in public-private partnerships. So it's non-monetary, but it makes my life as an entrepreneur, because everybody who runs a nursing home is an entrepreneur, easier. And I will be incentivized. So there is actually a lot to talk about, but at the end of the day, pricing, the ability of government to work as a payer, and the ability to make a public-private partnership into a win-win situation, rather than being skewed towards any one partner, is perhaps what will be key in public-private partnerships.
So just before we wrap this up, I have one last question for the two of you all. You all can take turns in answering it. What is your vision and how do you plan to implement your learnings and experience?
So my vision would be that I always believe in being in the army, catch them young. And I firmly believe that the problem of infertility doesn't come up overnight. It is there. It's already existing. So we have to go to the basic grassroots and educate people. So in case I have my call and I become the PM of the country or somebody bigger, what I'll do is that I'll reach to all young children, young boys and girls, schools, educate them about tuberculosis, chlamydial infections, PCODs, endometriosis. See, it's no use getting them to us when their tubes are blocked or they've got very bad endometriosis or they've got frozen pelvis. Reach people. Outreach will be my mandate. Reaching people at their doorsteps. And it is a big myth, एक बहुत बड़ा myth है हमारे देश के अंदर, women empowerment का. We always talk about empower the women. But I think we have come to a point where we have to empower the men. 70% of the reason of infertility or subfertility lies with the men. No one talks about the men. No one talks about male sexual disorders. We are only very happy talking about low sperm count. But men is at the receiving end now. So I'll raise this point here with your permission that men also has to be empowered. That will be my mandate starting from the small towns.
Thank you so much, sir. Dr. Tank, your take?
Well, I suppose a very utopian vision would be safe, respectful, and quality care for all women in the country. And I'm not sure what I would do to implement that. I think the investors in the room have to answer that question. Because at the end, I think people must understand that healthcare needs money. We always keep on talking about money in a bad way. Particularly when we are doctors, we are somehow, slotted into this noble profession piece. And any doctor talking about money is not regarded as being noble enough, if I may say. So we need to get out of this narrative. So the second part of my vision actually is narrative. And, you know, I already talked about how healthcare providers, clinics, generally the healthcare ecosystem is perceived. And as I said, I'm going to be the FOGSI president next year, and I've already started working on research I'm doing with the Packet Foundation to look at where these narratives have come from. To give you an example, one narrative is doctors are judgmental. And I'm going to go and do a extensive desktop research over the next 6 months to try and find out what evidence is there in literature to support this narrative. And if there is evidence like that, then I think it's high time that we start asking doctors why we behave the way we do. The fact that doctors are judgmental has been taken as something for granted. Nobody questions. When I go to all these meetings and somebody says doctors are judgmental, everybody says, हाँ भाई वो तो है ही. But nobody asks, why are doctors judgmental? Nobody asks what makes doctors behave the way doctors do. So this is the second part of my vision. I want to research this in a very deep way, because I think till we don't research and we don't understand physician behavior or why physicians and healthcare providers behave the way we do, any intervention we design to modify these behaviors is not going to be successful.
Thank you. So I think we can take one or two questions max, if there are any. None. Okay. We can wrap this up. Thank you so much.
Thank you, Prabhat. Thank you. Thank you, sir.